difficult,
Yeah,
unfortunately.
yeah.
Yeah.
And tell me what this president is doing.
Well, the current president is doing nothing, and the new president hopefully will be doing
Okay,
something
please
significant.
Okay.
Yes. Hmm.
start now, please.
Yes, go ahead.
Okay, it's my great pleasure to be here with you. Welcome, everybody. We will start the third webinar of International Society of Health Education about guidelines and best treatment options for patients. May I ask Dr. Salman Rawaf, the chairman
Thank
of
you.
society, to start the webinar by welcome letter.
Professor Maithan, thank you very much indeed. Good morning, good afternoon, good evening, wherever you are, and delighted to meet you again in our third webinar session. And this session actually focusing on an important issue, still an important issue, on COVID treatment. We still have very large number of people admitted to the hospital, although the prognosis is by far much better than last March and indeed April, May. Treatment is still challenging because we don't have any specific drugs which we can say this is anti-COVID drug. I know research is going on, including my institution. But having said that, all the treatment we got are supportive treatment or some existing treatment under trial or experimentation by colleagues in different sites around the world. We are very lucky, extremely lucky. We have some of the top experts in the field. They come from the front line, not from textbook, and they will share with you their specific experience in dealing with COVID in all ages. I'll hand over back to Professor Maithan to introduce our distinguished and eminent speaker. And I'll join you later on in the discussion. Professor Maithan, to you.
Okay, thank you so much, Dr. Salman. Now, Dr. Majid Jawad, he will talk about risks of lack of adherence to guidelines.
Thank you very much, Maitham. Thank you. And I thought this is generic and not just related to COVID only, just in case, just to clarify this. That's what my understanding of the title. And thank you, Professor Salman, because I can't compete with Professor Salman and other experts in their fields in COVID. So I want to claim any things, okay? So this, I was asked to talk about, you know, the views of the societies and medical, if you like, unions, which means the risk of non-adherence, about risk of non-adherence to guidelines. In order, and because you asked me to be the first, so I'm trying to share. It doesn't.
Okay.
Can you please enable me?
Yes, yes. My pleasure.
In order to, because you asked me to be the first, I'm going to have to give you some background about what's guideline, just quick. Okay. Shall I share? Yeah.
Yeah.
All right. So guidelines are based, you know, on the concept of evidence-based medicine, the definition of which is goes back to 1994 by Sackett et al., where it says it is the integration of clinical expertise with the best available clinical evidence from systemic research. So it's not just a personal opinion, okay? And it's not, doesn't come from experts, no matter how good they are, like Einstein, or just textbooks, or but it's a combination of everything, okay? And the evidence, it's as I said, the integration of individual expertise with the best evidence. We normally, it has 5 steps. We normally ask the question, what is the effect of this? Is there any diagnosis for this? Is there any treatment for this? Something. Then we assess whether there's an evidence for it, anything that we can use. If there is, we assess the quality of it. and then the finding from the evidence, and then the application. So this is the details of it. Asking the question about treatment, diagnosis, anything, and then acquiring the evidence. We look at textbooks, data, etc., and then appraise. We see how good it is. Is it a small data? It is large. It is well-designed study based on well-designed studies, and applying the results. And then, of course, it's our performance. And as I said, it can go to treatment, harm, diagnosis, prognosis, any question. So when we ask the question, okay, there are in history a lot of bad practices, or not based on evidence, such as use of thalidomide, which is still, by the way, used in myelomas. Okay, it can cause phocomelia, amputation of babies' hands. Babies sleeping poor because sudden infant death syndrome, aspirin in kids, Rice syndrome, etc., etc., or no benefits such in other medication. So what's the best mode to answer the question? It is the research. It is the one which answers the new question, okay? Which is a structured activity intended to provide new knowledge, as you know, which is generalizable. It can be used on Asians, Africans, Americans, everywhere, okay? And the best, we go to this big pyramid where you have the top of it. It has the best filtered information like systemic reviews and critically appraised topics, etc. And the bottom line is the unfiltered information like cohort studies and background and personal opinion. These are not the greatest. The greatest are the top. Okay. So when we ask the question, we answered it by the research. We assessed it. We went to what we said before, the systemic reviews. We felt comfortable using it. So what do? We establish evidence-based guidelines. That's when we build the guidelines, okay? And then we implement them in a clinical practice, okay? Every area, and nephrology, oncology, whatever, research and guidelines based on good research and filtered information on each areas. And then what we do clinical audit. We audit our practice to see whether we are doing it right or not against the standards background. That's the audit cycles. I'm not going to go through the audit. Just, you set your standards, you measure your practice, and then you compare it and you re-audit. Okay. It's a quality improvement of our work. The first in history, by the way, who used the audit is Hammurabi, King Hammurabi. He used to punish surgeons who do not do their work right. Do you know by what? By cutting their arms. Typical Iraqi dictator. Okay. So just out of interest, but Florence Nightingale and the Harb al-Qarim in Crimean War did the first audit. Beautiful observation of death, 40% among soldiers who are infected, reduced by 2% by simple observation, just washing hands, just hygienes. Okay, so the audit and all our work in the hospital, in every hospital, every trust, it's called, it's based on a clinical governance pillars. These are the pillars for the clinical governance, where we manage any hospital, any project, any not only hospital, company, anything. Okay, but in hospital we have the clinical audit, clinical effectiveness, and the what we have risk management. That's where it comes, the lack of adherence to guidelines, part of risk management as part of the clinical governance. Okay, one of the pillars. So what's risk management? It's the risk management is uncertain event that may have either positive, which is a good effect, or negative, which is the harmful one. So our task is the process of identifying the negative side and mitigating it, reducing it, and the improving the positive one. Okay. Risk adherence, for example, to guidelines. There are lots of studies. Guidelines, by the way, the guidelines implies that they are guide or signpost to us. It is not written on stones, but they are based, because they are based on best research evidence. So we ought to follow them ideally. Okay. And now most of the medical unions, protections, general medical council ask you the first thing: did you follow the guidelines, evidence-based, before you treated that patient? You know, if that patient was harmed, for example. That's how you protect yourself as a doctor and protect your organization. So there are strong recommendation, a set of strong recommendations we must follow, unless we have a very good reason not to follow. Okay, so dangers. There are studies, for example, by the way, there is the other side of the coin. There are some guidelines are over implemented, like in some cases, in some studies, in ICDs, 23% did not need them. That's you know, implantable cardiac devices for those who have sudden VF or ventricular fibrillation or thing. Okay, so that's as was in JAMA, a big study. So there's the other side of the coin. But despite high number of internationally produced guidelines, there are still sometimes areas and countries where the implementation or applying adherence to it low. They interviewed lots of physicians in one of the studies. They want to find why they don't apply to these things, and they found various reasons. Either lack of familiarity, they are not familiar, so it is our responsibility to educate them, or perceived limited validity. They don't have, they think it is limited validity. Why should I apply? I am the most expert person. I'm Professor Abbas, I know better. Okay, or limited applicability of guidelines among certain people or aspects. يعني احنا we should not copy and paste. Certain areas need to modify the guidelines. يعني احنا ما نستعمل the exact guidelines, American or British, exactly as they are in Iraq. We have to adjust sometimes. Okay. Clinical inertia, which is, you know, inertia. You're not as active, or a lot of an influence of prior anecdotes. If you have previous you know, ideas which is wrongly seated. Okay, and medical health statistics. These are the metaphysics, if you like. Okay, the abnormal ones. Okay, the unapproved thoughts. Okay, measures of improving guidelines, record prescribing. They found that they focus on measures to improve physician education, the most important, physician education, and increase their awareness, and implementation of physicians, for example, in drugs, pharmacist co-management strategies with the physician to teach them and to show them. I'm going to finish. Most guidelines are based on this, as I said, on questions, treatment, harm, diagnosis. We have to apply them. And in health, management, clinical risk in healthcare, we manage risk in healthcare. It is universal challenge. Okay, and a robust decision against accusation of being partner. It's a very important. It prevent accusation or minimize it. It protect the doctor, protect the organization, the hospital, and the medical field. Protect the patient. Improve our, you know, integrity, and so if we are not sorry. This is the last. I have a slide before that, which is the summary of it. I'm afraid I lost it. The summary of it is that adherence to guidelines is vital because you know, it's protect the organization, the doctor, and the patient. Okay, in effect, and because it's based on the best evidence, most and it's legally bound in lots of it. So be prepared rather than it's too late. Don't read in there. Okay. Thank you very much.
Thank you so much, Dr. Majid Jawad, for this topic. Now.